Good morning, everyone. Good morning. I'd like to ask everyone to please take a seat. We're going to get started in just a moment. We'll have everyone get their coffee and come on in and get comfortable. Okay, let me know when you're ready. Ooh, we got suddenly quiet. Well, good morning, everyone, and welcome. My name is Victoria Velajko, and I'm the Senior Vice President at Susan G. Komen's headquarters in Dallas, Texas. It's welcome everyone here to the historic National Press Club. It's been really interesting to spend some time here in the hallways this morning to see all the photographs of, important moments in history. But I would like to encourage the National Press Club to put a picture of all of you up on the wall. Yes, right, thank you. This is right, because we're making history right now. It's because of the metastatic breast cancer community that we are witnessing a sea change in how breast cancer organizations are now talking about breast cancer. It's because of you that we are now shifting away from conversations about awareness to finally taking action, putting a laser focus on demanding more research, more community support, and more education about those who are living with metastatic breast cancer. And it's because of your advocacy that groundbreaking partnerships are now evolving to be in service of what you're asking us to do, including the unique partnership that we've had with our colleagues at Living Beyond Breast Cancer to bring this symposium to you all today. But the partnerships are becoming much more deep and much more complex. Living Beyond Breast Cancer and Susan G. Komen are very proud to be members of the Metastatic Breast Cancer Alliance, in concert with lots of other organizations that are evolving to better serve this community. So I want to thank you all for making that happen and helping us develop our shared commitment to listening to your voices and elevating attention on what you're asking us to do. As Ana Cabanas had mentioned, elevating those voices also means communicating to communities in the way that they feel most comfortable, which is why we're so excited to have a session entirely in Spanish at this conference today. Thank you. I want to thank our friends from Nueva Vida who have helped make this happen and encouraged us to really elevate the conversations in the language where people feel most comfortable expressing themselves and talking about their journey. So we're excited to make that happen too. We're also excited about the response to this symposium. We've had over 180 registrants, and I want to point out that we also have a number of healthcare providers in the audience and caregivers. So again, thank you to all of you for coming and standing with this community. It's incredibly important. But also, we're live streaming. For those of us who aren't able to join us in DC, through a sponsorship from AstraZeneca, we're making it possible for our folks to watch our program today via Facebook. So thanks also go. Yes, hello folks at home. So hello. Okay, so everyone's going to be able to participate. So I want to stop and just, make this announcement as well. For those at home and for those right here in the audience, you can ask questions and interact with our presenters today via text message. So I know you're supposed to silence your cell phones, but it's okay if you have your cell phones out on the table, because if you want to ask questions, that's how it's going to happen. And my colleague Erin here, wave Erin, she's going to help moderate the questions for us. So the number for text messaging, and again, Janine's going to mention this again, but you can get your cell phones out now. It's 610-365-7532. So I also want to thank our sponsors who are making this morning possible today, Pfizer, Lilly Oncology, and Celgene. So thank you for your support. But most importantly, the people that we have to thank are the metastatic breast cancer community and advocates who have helped craft this program. It's my pleasure to introduce one of the strongest advocates I know. Her name is Jamel Rivers. And she is a member of the Living Beyond Breast Cancer Board of Directors, a member of Komen's Metastatic Breast Cancer Patient Advisory Council. She serves as a research advocate. She serves as a public policy advocate. And she's also doing all this while she's raising a family of 3 boys. Yes, she's amazing. Now, I'm not saying she's Wonder Woman, but I've never seen the 2 of them in the same place at the same time. So it is my honor to introduce Jamel Rivers.
Thank you, Victoria. Wow. Well, as a board member of Living Beyond Breast Cancer, I bring greetings from our home base in Philadelphia. We are really pleased to be working with Susan G. Komen to bring an educational program on metastatic breast cancer to this region. LBBC has a rich tradition of programming and support for people living with metastatic disease. If you're available April 5th through 7th, head straight up Route 95 to Philadelphia and attend our 13th annual conference on metastatic breast cancer. Today's program is an extension of our ongoing commitment to people like me living with METS. And while we have planned a day of education for you, we also expect to learn from you what kind of ongoing programming you want to see in this region going forward. I want to send out a thank you to the Thelma D. Jones Foundation, Tiger Lily, and Nueva Vida, 3 wonderful nonprofit organizations for helping us build today's audience. We also had members of the local community helping to shape today's program. I'd like to introduce you to 2 of those members, Julia Maues and Roxana Guerra.
Hello. It's really nice to see so many familiar faces and people that I've met over the years. I feel like this is a very special day, and it's a very special place to be at. I want to especially mention 2 groups of people. One is 3 friends that passed away this week. So Helga, Nancy Ray, I think about you all the time, and Delia. And also the other group of people that I want to recognize is everyone out here that does not have cancer. If you're a caregiver, if you're working for LBBC, if you're a doctor, my doctor is here, and I thank her for dedicating her life to improving our lives. So it's really, really important for us to have partners that are here. And if you're a spouse, a friend, a researcher, and you're here on your own time because this matters to you and not because you have cancer and you kind of are stuck with this reality, thank you. So I also want to thank Komen and LBBC for bringing us patients to this planning. We had many things to say, and they listened, and they made changes, and it's very important that we are included in these conversations because we have a voice. We want to be included in the decisions that affect us. Like a friend once told me, if you're not at the table, you are on the menu. And we want to be at the table. So I'm excited for everything else that will happen today. Roxana will talk about everything that will happen in the Spanish session. Thank you.
Buenos días, bienvenidos. Mi nombre es Roxana Guerra. A mí me invitaron al grupo LBBC y Komen, que fuera parte de hoy, y ayudar a mis hermanas latinas y ser voz para ellos hoy. Y quiero darles las gracias por la invitación para ser parte de este comité. También quería decirles también que hoy es la primera vez que tenemos esta conferencia en español y estoy muy feliz que estoy parte de esto y tener la oportunidad para todos que podemos expresarnos y conocer diferentes gentes hoy y otras amigas y amigos, familiares y bueno, para estar cerca con todos nosotros y bueno, suerte para hoy y espero que le den mucha información hoy. Gracias.
Thank you so much to our speakers for setting the tone that this is really for the patients, by the patients, of the patients, about the patients. I want to announce we're going to be starting our first session, but no habla español, but I'm going to try. So, para la sesión en español, por favor, siga Ana. Gracias, Sesame Street. I know. Okay, so my Spanish is terrible. I tried my very best. For those who would like to participate in the Spanish session, please join Ana in the back of the room, and she'll take you right next door to the Mara room. Okay. Gracias. Gracias, señor. You're very kind. Great. We're very excited to be able to have a special session for our guest next door. Okay, so we're going to get started in this room with Dr. Isaacs and Janine, so I'm going to switch over.
Hi, everyone. My name is Janine Guillermino, and I'm the Senior Director of Programs and Partnerships at Living Beyond Breast Cancer. And we're so happy to have all of you here today. So happy, as Julia said, to see so many familiar faces and to meet some new ones. So thanks so much for being here. So we are going to start with our plenary session, which is called Treating Metastatic Breast Cancer. And in addition to all of you, as Victoria mentioned, we do have hundreds of people joining us on the live stream. So why don't we give them a good morning and say hi so that they know we're here and that we appreciate them. Thank you so much for being with us. I'll be moderating this morning's discussion with my colleague Victoria, and we're very fortunate to have with us Claudine Isaacs, who's a medical oncologist at the Lombardi Comprehensive Cancer Center at Georgetown University. So thank you for being with us, Dr. Isaacs. We have a lot to cover in the next hour and a half. We're excited to talk to you about new treatments available today and clinical trials, as well as what you can be expecting down the pike. And the way we're going to organize our discussion is to talk about the disease by subtype, and we'll be taking your questions throughout. So just to give you that text number one more time, it's 610-365-7532, and you can put that in your silenced phone and text us questions throughout that Erin can take throughout our conversation. With that said, as I said, we're going to talk about each of the subtypes. We'll start with hormone receptor positive, then triple negative, and then HER2 positive. But as many of you, I'm sure, know, we think that there's probably many, many other types of metastatic breast cancer. So I wanted to start, Dr. Isaacs, with asking you, why do we organize things in this way still? And why is it important?
So the reason that we organize it, first of all, thank you all for being here. You know, I represent many people, and I think as people who try and make a difference, what we're really trying to do is through research and through advances to really increase benefits and increase treatment options for all stages of breast cancer. But metastatic breast cancer is an incredibly important stage for us to be looking at, and what we're trying to do is to find better and newer and more tolerated treatment options to hopefully one day increase the chance for cure and improve just outcomes in general. So I thank you all. Everyone's here on a Saturday morning, and so I really thank you for being here. We talk about breast cancer in subtypes because they allow us to think about more specific targets. I think everyone is hearing this concept of individualized or tailored therapies for cancer in general, right? And what that really means is that drugs are developed that hit a specific target that might be important for the cancer cells to allow them to grow and to spread and to do all these things that we don't want cancer cells to do. So what we try and do, and what we've done for breast cancer really for many decades, is have different subtypes that have specific targets that we understand are important and that drive the growth of the cancer cells. So we divide it into hormone receptor positive because hormone receptor positives are tumors that are either estrogen receptor positive, progesterone receptor positive, or both, and that is an important target for the cancer cell, and so we have a series of drugs that have been developed that target those receptors. HER2 positive is another target that's really important for growth of the cancer cells. And I've been doing this for long enough that I remember when HER2 positive was really the most aggressive subtype, but with the advent of therapies that target HER2, target that protein that is overexpressed in about 15 to 20% of breast cancers, by targeting that, drugs have shut that down and have really changed outcome for people. And then triple negative is a subtype that we're really really focused in terms of trying to develop and identify targets, because right now the only treatment that is currently available are standard chemotherapies, but there's a tremendous amount of work right now at trying to develop drugs that target triple-negative breast cancer. And I think, as you were alluding to at the beginning, is yes, these are groups, but within them, there are many different subtypes that we're trying to tease out. And so we know that there can be additional drivers in some subtypes that we could think about targeting. So they're not, these are the groups that we currently have today in 2019, but we're starting to subgroup them, and we're starting to try and develop additional targets for the different subsets.
And we'll probably talk more about that throughout our conversation today. A question that we often get is how often people with metastatic breast cancer should get a biopsy or rebiopsied, and when.
So that's a great question, and one that is evolving. So the good news about medicine is that it is changing at an incredibly rapid clip. So what I say today will probably be different than what I would say, or what we as healthcare providers will say in 6 months or 12 months or 2 years or whatever. We used to just biopsy. Many of us were taught to biopsy initially at the time that we suspected that somebody had metastatic breast cancer, because we could think that that's what it was, but you need to be 100% sure, because it's obviously very important to figure out whether somebody has metastatic disease or not. And then we also were taught to biopsy to make sure that the hormone receptor status and the HER2 status remained the same as on the primary. And we have good information now that while most of the time it's true, somewhere between about 5 to 20% of the time, the receptors change. And they change on the site of metastasis compared to the site of the primary. So it's really important to sort that out. So that was what we had been doing for quite a while, is biopsying at the time of initial recurrence to confirm that. But increasingly, as we're starting to find additional targets, people are thinking about biopsying more frequently at the time of maybe deciding about next type of treatment. And part of that is because we can now send specimens off, tumor specimens, and there's some data there's some studies looking at blood specimens as well to look for specific mutations or alterations that we could target. Right now, that's actionable in some cases in standard of care, but it also makes a big difference when we're thinking about clinical trial options that are looking at some of these newer targeted therapies as well. So some of what we find now tells us that we should be thinking about immunotherapy in breast cancer. There are some rare cases where there are some drugs that are approved for specific alterations in the tumor, and we can only find that out in a clear way in breast cancer right now by doing a biopsy. But obviously, we'd prefer to be doing as few invasive things as we could. So we're also looking at circulating tumor DNA and trying to figure out just on blood tests if we could determine that.
Sure, and for people who need a biopsy of the tumor itself, what are some of the considerations about why you would do that or why you would not do it?
Why we would do a biopsy or not do a biopsy?
Right.
So there are a number of things that come into play there. We are always thinking about the impact of a biopsy. How accessible is the tumor? Can one of my colleagues, it wouldn't be anyone like me who would be doing something like that. It's typically interventional radiologists who do these biopsies, or breast imagers, or various people like that. So we always try and figure out, is it actually feasible? And then of the places that it might be feasible, which place would be the easiest for the person? The least painful, the least risky comes into it. And then we also try and make sure that the biopsy, if you're going to subject somebody to a biopsy, you want it to have something that we can actually act on. Is it going to get enough tissue for us to be able to interpret it, to potentially act on it? We're not just doing these things for academic purposes. We need it to have an impact. So for instance, if we have a choice of different sites, we tend to avoid biopsying bone, because for a pathologist to handle a bone specimen, they have to do something to get rid of the bone, right? So they have to do a process that decalcifies or gets rid of the bone, but that can also change what's expressed in the tumor, so it can give us false negatives. So, we're really trying to figure out if it's feasible and what what will be the least intrusive for somebody is really a big thing. So whenever I'm thinking of it, I tend to pick up the phone, and I know we're all supposed to text and do all these things, which I do, okay? But I find that talking to people is actually better. So I pick up the phone and I speak to our interventional radiologist, and I say, could you have a look at this and tell me what site do you think would be amenable to biopsy, and what would be the easiest for somebody to be subjected to?
Sure, sure. Thank you for that and for explaining the role of the interventional radiologist. It kind of shows the importance of having a team approach to treating the disease.
And I think when you're talking about a team, there are a lot of people behind the scenes. There's the interventional radiologist, there's the pathologist, people that people never see, but that are really important to the whole healthcare team that's trying to help us approach this.
Sure, sure. So let's move into talking a little bit about hormone receptor positive breast cancer, because so much has happened over the last few years. For this, this is the most common type of metastatic breast cancer, either on its own or coupled with a HER2 positive diagnosis. Today, what are the standard treatments that someone could expect if they're diagnosed with an ER positive or NPR positive breast cancer?
Right. So again, maybe to set the framework of this again, when I and my colleagues think about how we would approach metastatic breast cancer, the good news is that there are lots of effective treatments. Okay, there are tons of them. And the choice that we as a team should make, so your healthcare provider with you should make, is really of the options that are out there, which are likely to be most effective, and of the ones that are likely to be most effective, which one is best tolerated, okay? Because what we need to do is provide the best quality of life that we can with the least impact on symptoms that we can, because we want people to be thriving and to be living as well as they can, okay? So in terms of hormone receptor positive breast cancer, when I first started, we were taught that if anyone had any evidence of metastasis beyond into organs like liver or lung, we should be using chemotherapy. Mercifully, we've come a long way from there. And so now for most women with hormone receptor positive metastatic breast cancer, we're really thinking about hormonal therapy or endocrine therapy. And we're a teaching program. I teach our fellows and our residents and our medical students that the default now should be hormone therapy, maybe with something. And there might be instances where we think that's not the right thing, but most of the time it is the right thing, at least to start with. And so we're thinking about hormone therapy, and it really depends on the line that we're talking about. So the standard first line treatment for hormone receptor positive, HER2 negative metastatic breast cancer is a combination of some sort of hormone therapy, which is really an anti-estrogen therapy, plus what is now, it's still a relatively new class of drugs, but a class of drugs known as CDK4/6 inhibitors that gained FDA approval very rapidly, one after the other, and there are 3 in that class that are all very effective treatments that are given in conjunction with the hormone therapy. That the reason that they really jumped to the forefront here as opposed to hormone therapy alone is because they do carry relatively little in terms of side effects, nothing, so I don't want to minimize what we're talking about, but they're very, generally they are well-tolerated therapies. They're oral therapies. They allow people to live their lives not attached to infusion centers. And that's really what we're trying to do. And they added significantly over and above what we could do with standard hormone therapies. So they caused a greater number of women to have a response to it and to have a more durable response. So a significant prolongation in time until the cancer progressed on the therapy. So that's our standard first-line therapy today, is to use for women who have metastatic hormone receptor positive disease to think about hormone therapy alone. And the hormone therapy partner can be a number of things. The things that we have evidence for that are FDA approved for this indication are really any one of what we call the AIs or aromatase inhibitors, drugs like that. And all our drugs have 2 names, right? Just to make everyone even more confused. We have tons of drugs and they have, their marketing name and then their standard name. So I'll say both, okay? But drugs like letrozole, which is also known as Femara, anastrozole, that's also known as Arimidex, and exemestane, that's known as Aromacin. So those drugs are drugs that we can think about giving with these CDK4/6 inhibitors. And there are 3 CDK4/6 inhibitors. And then there's also another endocrine therapy that is an injection that's known as fulvestrant or Faslodex that you can give as a partner with it. So that's really our sort of first-line armamentarium for where we're going.
So you talked a little bit about the reasons why you might choose one over the other. Another question that we get a lot is, particularly with the CDK inhibitors, is if you've taken one and you have a progression, can you try a different one? And I'm wondering what the guidelines are for that today.
So the guidelines today are that we don't have any evidence that we should continue a CDK4/6 inhibitor upon progression on a CDK4/6 inhibitor. There are studies that are looking at that. There are studies that are adding other drugs that we think might reverse resistance to the endocrine therapy and or the CDK4/6 inhibitor. So again, you'll hear this over and over again. I'll try not to say it too many times, although I probably will. Research, clinical trials are what have gotten us to where we are today, but they're going to get us somewhere further tomorrow. And I think that it's not only the medical community, but I think that the patient community has, I think we all understand they're used to this feeling that people were being guinea pigs. And I think what we've really understood is that by carefully thought out clinical trials where people really think about the pluses and minuses and how it applies to them, if they feel comfortable on it or not, that's how we'll continue to make advances. But there are a series of drugs that are being looked at to try and overcome resistance to CDK4/6 inhibitors. But generally, the standard of care is if somebody has had appropriate therapy, was able to get enough of the drug in, you would not switch to another. There are some caveats. Medicine is like, it's not a black and white thing, okay? You probably have guessed that already. But there are some instances where people really, because of side effects, can't tolerate one of the CDK4/6 inhibitors and come down to really what we think might be subtherapeutic doses, so doses where we might not be able to see really the benefit or the effect. And so sometimes then we do change, and we try another one because we think somebody hasn't really gotten a fair run of one, or they were changed because of something that wasn't entirely clear whether the disease was really progressing and whether that was the right call. But the standard thing would be that, except in the setting of a clinical trial, we shouldn't continue CDK4/6 inhibitors.
Okay, thanks for answering that question. And just a really quick one, you mentioned that most of these clinical trials have been done in women. I'm wondering whether we know anything specific about using anti-estrogen therapies in people with male breast cancer.
So I probably misspoke. Many of these trials have only been done in women, but I think increasingly these trials are being done in men as well. And obviously it is rarer for men to have breast cancer, but it does occur. We have some data in males, and we're part of one of many institutions that's trying to get a male breast cancer registry, and hopefully through that registry eventually be able to carry out international trials with a large proportion of men so that we can really understand that better. We know that some of the drugs work, so tamoxifen is effective in males. We actually don't have great data on aromatase inhibitors or AIs in males, although it's something that we sometimes consider, nor do we have good data on fulvestrant or Faslodex, nor do we have good data on CDK4/6 inhibitors. That being said, our general approach to breast cancer in men is to do the same thing as you would do in women, because the studies that have been done to date suggest that it's the same. When you're talking about hormone therapies, it gets a little more complicated because obviously male hormones are different than female hormones. But when we're talking about drugs like tamoxifen, we have good data. There's no reason to expect that CDK4/6 inhibitors wouldn't work as well in men as in women. So those types of general principles apply.
Thanks for answering that. And again, just kind of pointing out the importance of clinical trials and having people be involved. So I see we have a number of younger women with us today, and I'm wondering if you can talk a little bit about some differences in treatment for premenopausal women with ER-positive breast cancer.
Absolutely. So for premenopausal women with ER-positive breast cancer, the hormone therapy that has been most studied is tamoxifen. Our other hormone therapies, so the AIs and Faslodex or fulvestrant, only work in women who are menopausal. That's just because of their underlying mechanism of action. So the AIs are drugs that block non-ovarian production of estrogen. So if somebody is premenopausal and they have ovarian production of estrogen, the AIs are not going to work. And fulvestrant is a drug where, at least at the dose that's approved, we think only works at that dose in postmenopausal women. So for premenopausal women, one of the things that we can always think of is tamoxifen, but we can also use other mechanisms to make premenopausal women postmenopausal. So the standard recommendation for premenopausal women is that we can use the same drugs as we would use in postmenopausal women, but add on ovarian suppression as treatment. So we make those women effectively, from a hormonal perspective, postmenopausal, and then can offer the same therapies.
Great, thanks for answering that. And is there a role for surgery as well?
In terms of ovarian suppression?
Yes, sorry,
Yes, there is. Again, we all practice probably a little bit differently. I tend to start off, so there are three ways to suppress the ovaries. One way we don't do very much in the US at all, but you can radiate the ovaries, but that's not something that we do, but it's one of the things that you may see that people are talking about. The other way that we do it more commonly is to give an injection, a shot, either monthly or every 3 months, to turn off that hormonal axis, okay? And then the third way is surgically. And the surgery, again, speaking as a non-surgeon, it's a relatively straightforward surgery. In the realm of surgeries, though, for people, it is generally a relatively easy surgery. It's a laparoscopic procedure, and it tends to have a rapid recovery for most women. I tend to start off women with a shot to see how they tolerate, because it's all about quality of life too. I think of every decision at every point with somebody with metastatic disease, that you're really trying to think about, amongst all the options, what are they, okay? What makes most sense among them? How does somebody's personal take come in on this, okay? So if somebody wants to go to the beach and has a beach vacation for a month, it would be foolish to choose weekly chemotherapy. That's like really messes things up, and that's not what we're trying to do, okay? So to get back to this whole concept of how you shut down the ovaries, I tend to start with a shot, because then somebody can see how they tolerate it. You can't put the ovaries back in, okay? But you can stop the shots. So I tend to start with the shot, and it depends on where somebody is age-wise. So if somebody is relatively close to menopause and they're doing great, and we think they're going to get a long run of hormone therapies, then it can get a little tedious to come in for monthly shots, and one could do the surgery. But I think that's a personal decision. It's not your doctor's decision or your healthcare provider's decision. It's your decision about how do you balance coming in monthly for a shot. If you're coming in monthly for something else, that might be better than thinking about some surgery. Mm-hmm. But surgery can come into play. And for people who live far away from healthcare places, it can weigh differently. So again, I think that's a very personal decision.
Great, thank you very much for that. And so we've talked about a number of different things. There are some other treatments that are being studied in hormone receptor positive breast cancer. We've heard a little bit in the past few months about PI3K pathway inhibitors, and I'm wondering if you can talk a little bit about those and some other things that we might expect to see in the near future.
I think you're going to see a lot of drugs with unpronounceable names. You sort of have to get the cadence right after a while yourself to try and figure out how to say these drugs. So these PI3 kinase inhibitors are, we know that PI3 kinase is actually one of the mutations that is found, or changes. So a mutation is a change, okay? It's a variation in the way that a gene is read or spelled. These mutations are quite common in PI3 kinase in hormone receptor positive breast cancers. So there has been a lot of research in developing PI3 kinase inhibitors to try and get at that molecular pathway in the cancer cell. So I think there are some encouraging phase 3 trials, which are the last generation, sort of the more definitive type of clinical trial, these randomized clinical trials that have randomized women to receive endocrine therapy alone or endocrine therapy plus one of these PI3 kinase inhibitors. And they're showing promise, particularly in women who have tumors that have these PI3 kinase mutations. And so I think that it is likely that we will start, that in the not too distant future, we'll have some of these drugs available. There are also studies looking at drugs with AKT inhibitors, which are other inhibitors along those pathways, and a variety of other genes or proteins that can be targeted as potential treatment options. So this is really, we are right now, what we don't have good evidence for in medicine is what to do after somebody has had disease progression on a CDK4/6 inhibitor. We have our standard treatments, and that's what we do, but we don't have good clinical trial data to tell us what is the best option. So there's a lot of activity in that space to try and figure that out, and a lot of trials are using these PRC kinase inhibitors, AKT inhibitors, looking at a variety of other things, other drugs that could reverse resistance to CDK4/6 inhibitors. Oral versions of Faslodex or fulvestrant are being looked at, so there's a lot of activity going on in that space.
And it's really exciting because there was kind of a long period where most of what we were hearing about were other types of metastatic breast cancer, and now it seems as though there's quite a few clinical trials open and available that are really looking at these questions. And it actually brings up a question that I was talking with a colleague about before the program, a question about whether to enter a clinical trial before you have progression, if you can even do that, or wait until you have progression. And it's actually a question that we hear quite a bit, people who are interested in going on a trial before they're even showing progression in the cancer.
So generally, I would not advise that. I mean, my general take is to keep on going and don't rock a boat unless you need to. Now, if somebody is not tolerating their current therapy, that's one thing. But if you're tolerating it and things are going well, then I tend to say let's keep on going on that as long as we can. And the good news is that I'm really bad at predicting the future on an individual basis. There are many people who are years out and doing well on the same treatment that if you'd asked us to give the stats, that wouldn't be the case. Okay, so you never know, and you really want to try and keep on going on that, because maybe, by the time that somebody has disease progression, we'll have something approved that's different, and we'll know about it. There are some trials where they are looking at specific targets, and sometimes we pre-screen the tumor to see if it has that target, so we can be thinking of it as the next step. But I always tell people, who knows whether, that trial might be closed by the time that we're thinking about that for you. So I tend to not come off something. But if somebody's not tolerating something and wants to look at something, yes, looking at trials makes sense. But again, the trials have lots of rules and regs on them. And it's not just because they're being pains in the neck, okay? They sometimes are. But it's because you have to be, the conclusions would not be valid if you kept on bending the rules of who went on and who you allowed on the trial. So these trials are quite rigid in terms of the various criteria that allow one to participate in them. And they typically, some of the trials might say it's not, you have to have had prior disease progression on a drug in order to go on. So it's not because somebody didn't tolerate it necessarily.
Sure. And thanks for talking a little bit more about that. I know that many of the advocates in the room are also working with FDA to talk a little bit more about ways they can become more eligible for clinical trials because of the standards of those trials.
And a lot of us are working on that as well.
Yes.
We recognize the barriers that we create. So I think increasingly as we're designing clinical trials, I know many of the groups that I'm part of in our institution, we always, we talk about these clinical trials with the breast cancer advocates. We're fortunate Julia is one of the wonderful advocates at Georgetown, and we have an incredible group of women who really help us with that. But a lot of the organizations that we're part of and that many people are part of have integrated. And I think what we have learned over the years is don't throw in some criteria that really doesn't matter. Something that doesn't make sense as an eligibility or ineligibility criteria, because that can exclude some people that we shouldn't be excluding.
Sure, absolutely. I think we're going to take a breath here and see if Erin has some questions for us from the audience.
Yes, we've been receiving quite a few questions, and one theme that has arisen, a couple questions have been asked about the role of surgery. So a couple scenarios. One person is asking in the de novo diagnosis setting, so initially diagnosed with stage 4, is it recommended to have breast surgery? And then there's someone else who is now, did treatment is stable, should that conversation come back into the treatment conversation?
So those are great questions. And we don't know the answer to that yet. We actually have, again, I guess I'm going to sound like a broken record. There have been a series of clinical trials that have tried to address that question, and they've had a really hard time enrolling because we all have biases, and it's the clinicians and the patients and everyone who has biases, and they, to do a clinical trial like that, you have to randomize people to it, and lots of people don't want to be randomized, or lots of doctors think that they know the answer to the question, so don't want to enroll people on those trials. So we don't yet have a clear answer for somebody who is diagnosed with metastatic disease. That's their first diagnosis. We do not know whether doing surgery on the breast changes outcome. There are some what are called retrospective studies, so people looking back in their databases or collecting information looking back suggested that the outcome of women who had surgery, who were diagnosed with what we call de novo metastatic disease, that those women did better. But that has biases, right? Because people are the people who are having surgery are healthier because you're sending them to, you wouldn't send them to surgery if they weren't, and people wouldn't agree to surgery. So we still don't know. That being said, we have to make decisions, okay, in the absence of good data sometimes. So it really depends, and I think it is a conversation that people have to have. And I particularly think about it in people who have few sites of metastatic disease or long disease control, like the second part of your question was. That is a time where that conversation should come back. And you and your healthcare provider should say, should I be thinking of surgery now for the breast? And there's also a discussion for people who have relatively few sites of metastasis, whether we should be doing more definitive local therapy for that. Should we be thinking about either surgery or radiosurgery or something like that in conjunction with the whole body treatment?
Thank you. That was a great question. And we go to the next question?
Yes, so someone is asking about the difference in treatments in terms of ductal and lobular cancers. So bringing that into the conversation too.
Thank you.
So lobular cancers tend to more commonly be hormone receptor positive and tend to get a little bit less benefit from chemotherapy. So we haven't talked at all about chemotherapy for hormone receptor positive, HER2 negative breast cancer, but it is one of the treatments, or one of the groups of treatments that we think about and that we use, because what we tend to do is start with hormone therapy, and we keep on going with hormone therapy as long as we can, because that's usually better tolerated than chemotherapy. But there are some chemotherapies that aren't so awful, okay? And at times, some of these other drugs, these fancy new drugs might have side effects that are similar to some of the chemotherapies. So you really need to think about what the best option is. But lobular tends to be a little bit less responsive to chemotherapy, so it might push one even more to think about hormone therapies than chemotherapies.
Great, thank you. Do we have another question, Erin?
We do have many, but it's hard to pick and
Not
choose.
surprising.
But linking to the conversation about clinical trials, wondering if there's any promising clinical trials to pay attention to in this space with hormone-positive metastatic breast cancer or going on.
So there are, I think that the PI3 kinase inhibitor trials, the AKT trials. There are also trials that are getting underway with immunotherapy, which is something that I think we'll come to when we're talking about some of the other breast cancer subtypes. Hormone receptor positive breast cancer has been more traditionally thought of as what we think of as a cold tumor, meaning that it is not responsive to immunotherapies. But there are trials underway or planned that are going to try and address whether one can think about using immunotherapy or which subsets of hormone receptor positive disease might one be able to consider immunotherapy as a viable target.
Thank you. Let's take one more question.
One question is about testing for the inhibitors. Is there any sort of test, or how is that monitored? I'm not sure if it's asking, the question is asking if it's working or if you're a good candidate for that, something about testing. And
are there any biomarkers, probably,
Yes,
any way
yes,
of
I
knowing that
believe.
someone's more likely to
Right.
respond to the treatment?
So that's a great question, and that's been looked at. And there are no biomarkers that we can find so far aside from hormone receptor positivity.
Right.
There has been a lot of the clinical trials have looked at that. So You might also be aware that most of the clinical trials try to gather some sort of what we call biospecimen in a really technical term, meaning either tumor tissue or blood or something, because what we recognize is that while treatments might work in some people, they don't work in everyone. And we need to figure out who those some people are. We also need to figure out the people who they don't work in, why they don't work. So maybe we could overcome that and figure out how to get around that blockade. So in the trials with the CDK4/6 inhibitors, there have been a lot of further study on the material that was gathered as part of those trials to identify predictors of response or non-response, and nothing has really panned out so far. So we don't stratify, we decide that everyone, basically what we do today is everyone with hormone receptor positive, HER2 negative breast cancer, we're thinking about using the CDK4/6 inhibitors. The other thing that I wasn't sure of in your question is, was the monitoring actually what do you do when somebody is on a CDK4/6 inhibitor? And there is some laboratory monitoring that you need to do on it. These drugs typically suppress the white blood cell count, so one needs to have complete blood counts done to follow that. So there's a certain amount of monitoring that goes on as part of treatment on CDK4/6 inhibitors.
Great, thank you for that question. Thanks for all of your questions. I'm just going to quickly give the text number out again for folks who may want to ask questions. It's 610-365-7532. And with that, Victoria, I know that you have some questions as well.
All right, we're going to move on to talk about triple-negative breast cancer. So we started out talking about a breast cancer that's defined by what we know about it, but triple-negative breast cancer has the unique distinction of being defined by what we don't know about it. And that would be like me trying to describe Dr. Isaacs as, well, she doesn't have red hair, she doesn't have blue skin, and she's not wearing yellow. But if I did that, you wouldn't be able to pick her out of this room because that describes pretty much all of us. So we've seen some exciting things in the past year and past developments about how this can be changing. We're learning more about it. We say that triple negative is defined by the lack of targets, but I think it's better to say that it's defined by the lack of known targets, and that's changing. So, but to start off, let's talk about what's standard treatment now, and then we'll move into how that's changing.
And that now might be changing in a few weeks.
Right, in a few.
So to bring your analogy further, I guess we want to be able to say that Dr. Isaacs has, short hair, has a Canadian accent if anyone picked it out in the crowd, and various other things. So we do know that triple-negative breast cancer is way more than one thing, okay? So we do know that it encompasses a variety of subtypes within triple-negative breast cancer. And there is a lot that is, again, being done to try and target those subtypes. So when we talk about biopsying, and we go back to the question that we talked about a little earlier, that question about biopsying and looking for targets applies to basically all breast cancer subtypes. Right now, the standard treatment is chemotherapy. And chemotherapy has been around for a long time. It can be effective. It has variable side effects or toxicities based on the chemotherapy itself. But we haven't had anything else beyond that, and we don't yet have anything else beyond that. But there was a recent large trial, and there will probably be another trial at its heels soon that we'll see the results on, looking at the role of immunotherapy for triple-negative breast cancer. And so there's a trial that was just, the results were just released a few months ago, that looked at adding immunotherapy to one of the chemotherapies for metastatic breast cancer. It was a randomized trial, and it showed that there was a significant prolongation in time to disease progression with the addition of immunotherapy, but only in a subset of women with triple-negative breast cancer. So that subset were women whose tumors expressed PD-L1. And the concept here is that our immune systems are supposed to recognize non-self, okay? That's what they're supposed to do. They're trained that if you have a virus or a bacteria, it goes into full gear, it goes and isolates that, and it destroys it. And cancer cells have somehow figured out how to fall under the radar screen, because cancer cells are not us. They're not self, okay? But they figured out a cloaking mechanisms. They've figured out how to hide themselves from the immune system. And one of the very potent mechanisms is a whole pathway that involves PD-L1, okay? And so there have been a series, when we're talking about immunotherapies, many of the immunotherapies are anti-PD-1 or anti-PD-L1 because that's a way of uncloaking, of letting the cancer cell not be able to hide from the immune system. So one of the things that can be tested on cancer cells is to look, or actually it's not only the cancer cells, it's our blood cells that are surrounding the cancer cells as well that can be part of that cloaking mechanism. And so there is a lot of hope that for women with triple negative tumors that are PD-L1 positive, or the infiltrating tumor-associated cells, so our white blood cells that are around there, that are really the cells that recognize and fight non-self, that if we add an immunotherapy to that, there is a greater benefit. So there was a significant prolongation in benefit and in survival in women with triple-negative breast cancer whose tumors or tumor environment cells express PD-L1. So I think that's going to be, you will see this, we think, if we can read the tea leaves of the FDA, okay, we think that this will probably be approved within the next couple of months, we hope, and maybe even sooner. And there are a series of other trials that are looking at that. And the thing is that this will be an evolving field, right? This is the first trial, but we need to understand more, and sometimes trials give slightly conflicting information or measure things a little bit differently. But there are also trials looking at some of the other drugs that we've talked about. There are trials with some of those same AKT inhibitors. Those cross different breast cancer subtypes. So there are trials looking at some of these AKT inhibitors. There are trials with different types of chemotherapies looking at whether they might be more effective. So there is a lot of work being done trying to look at different targets. Some triple-negative breast cancer cells express the androgen receptor, which is a receptor that's a male hormone receptor. And so there are trials looking at using androgen receptor inhibitors and a variety of things that are really ongoing. It's a very rapidly evolving field.
So you talked a lot about the emerging drugs that none of us will be able to pronounce. So there's one class of drug that has been in clinical trials, and those are PARP inhibitors. Yes. So would you like to share with everyone what the letters PARP stand for?
I don't remember what PARP stands for, but I can tell you.
I'm putting her on the.
Yeah, thank you. Hi, I don't know what PARP. I can't remember what PARP. I'm middle-aged too. Okay, so I can't remember everything anymore. I had a much better memory when I was 25 than I do now. So PARP inhibitors were actually a class that I hadn't alluded to yet. It actually is not just restricted to triple-negative breast cancer. So PARP inhibitors are drugs. PARP is an enzyme that helps to repair from DNA damage. Okay? So PARP inhibitors are drugs that inhibit that. So it causes, if you use a PARP inhibitor, the cell cannot repair from DNA damage. Cells are complicated. They usually have more than one pathway, okay? So they're not just relying, it's like, well, I'm not going to be very good at some analogy, but you know, I understand hockey, okay? So I'll do hockey for you. Probably you guys don't understand hockey Canadian. As well as I do. But you wouldn't just have one goalie because, you know, if your goalie was out, you'd be in problem. And that applies to soccer and I'm sure a lot of other things that you might know about. So, you know, cells are smart and they have more than one pathway. They're not just relying on one thing, because if you knock that one thing out and they're done, that doesn't work very well, okay? So there are lots of mechanisms to repair DNA damage. But PARP inhibitors hit one of those mechanisms. And it might seem to you that if you don't allow the cell to repair DNA damage, is that good or bad? And it actually ends up, if the cell cannot repair from DNA damage, the cell will die. Okay, and that's what you want cancer cells to do. So the place where PARP inhibitors have been approved is in women who have metastatic breast cancer, who have mutations, have inherited a mutation in either BRCA1 or BRCA2. Okay, BRCA1 and BRCA2 are genes that code for proteins. So genes code for proteins, okay? So somebody who has inherited a mutation in BRCA1 or BRCA2 has a change in their DNA, in the gene that's coding for BRCA1 or BRCA2. And we say that when somebody has a mutation, it means that that change in the gene doesn't allow the protein to be made. A defective protein is made or no protein is made at all. So you effectively do not have BRCA1 or BRCA2. And BRCA1 and BRCA2 are proteins that repair from DNA damage. It's a different pathway than PARP, okay? So if you have a woman who has a tumor that has a BRCA1 or BRCA2 mutation, that tumor cannot repair from one aspect of DNA damage, but it's relying on another. And then if you give the PARP inhibitor, you're hitting that rescue pathway, okay? So the cell cannot repair from DNA damage. So relatively recently, there was approval of PARP inhibitors for women with metastatic breast cancer who carried a mutation in BRCA1 or BRCA2. It was approved for women who had triple negative, but it was also approved for women who have hormone receptor positive HER2 negative breast cancer, which is something that people often forget about, but that is where the approval is, and that is where the data for benefit is. And the trials that were done basically randomized women who were going to receive first-line chemotherapy, or first-line or beyond chemotherapy for metastatic breast cancer with BRCA1 or BRCA2 mutations, randomized them to either get a chemotherapy that would be any one of the appropriate chemotherapies that we have as options, or these oral PARP inhibitors. And the trials with the 2 PARP inhibitors that have been approved to date showed that the PARP inhibitor was better. It prolonged the time to disease progression. And generally, because it's an oral therapy, it's a little bit more tolerable. And so those drugs have now been approved. There is ongoing work to see if these PARP inhibitors might work beyond BRCA1 and BRCA2 carriers, because that's a relatively small subset of people. So we and others have trials looking at PARP inhibitors in women who have either inherited a mutation in another gene that affects the ability of cells to repair from DNA damage, and that's a very complex pathway, and there are lots of different genes that can do it. And then the other question that has come up is, does the person have to have a genetic change, or could it just be in the tumor? Mm-hmm. And so the trials that we have open right now, and there are some other trials across the country also looking at that, is looking at the role of PARP inhibitors sort of beyond our standard, beyond BRCA1 and 2 carriers, where we can give it. And we can prescribe it. We don't write prescriptions anymore, obviously, so we type these things out. But where we can prescribe it and it's FDA approved, but the trials are actually looking at whether we can broaden them, because it really makes sense that it would apply beyond that. It could apply to mutations that somebody has inherited in other genes in that pathway, or if the tumor itself, when we send it off for that molecular profiling, shows that there's a change in one of those genes in the tumor, maybe these PARP inhibitors would work there too, but we have to look at it and we have to prove it.
There's one thing I'm learning just from this morning alone, and I think every woman in this room knows this, that one size does not fit all, especially with breast cancer. This is incredibly complicated, incredibly complex to plan the treatment journey for each individual. This is all about personalized medicine. And you talked a minute ago about, depending on which chemotherapy someone started with and what drug happened next. Can you talk a little bit about the timing and the importance of, what chemotherapy starts, what treatment comes next, and how that might dictate or how that might contribute to outcomes? How do you decide what comes first?
So in some cases, we have evidence. In some cases, we usually have a menu of options. Okay, sometimes studies have told us that it's better to do one first than second or third. But in many cases, we don't have that. Certainly for the chemotherapies, we often don't have that. We typically start in the metastatic setting with drugs like taxanes are often our first-line therapies. Sometimes for triple-negative breast cancer, we also have evidence that a different drug, a drug called carboplatin or cisplatin, might be more effective in that subtype of breast cancer. But typically, again, we're thinking about how somebody's other symptoms, health is. Are there other things that would push us more to one or the other? And then at other times, the thing that I always think of is, how does it impact somebody's life? Okay, what else are we doing? If we have a couple of oral chemotherapies, so my comment, if somebody has 3 weeks at the beach, well, and we know that it's in 3 months and we have to change therapies, well, maybe we should think about an oral chemotherapy here, because that lets you go to the beach and not come back to the infusion unit. I mean, so that's sort of, that's part of the equation too, if we don't have good evidence that one is better than the other. And in fact, it really just depends on when some of these drugs were developed, because the clinical trials are going to look at them in different spaces, and may not, because some were out of the blocks a long time ago, might not have looked at the sequencing with other drugs. Mm-hmm. So for some of these, we have clear indications, but for many of them, we have a choice, and the choice needs to be individualized and personalized.
I know we had a lot of questions from the audience, so I want to be sure that Erin has a chance to answer as many or ask as many as possible that are on her list.
We might have you answer them too.
I know, right? Ask and answer. One-stop shop.
Yes, they've been flowing in. So a few questions to follow up on the conversation about PDN1. So the first question is, what share of patients, or what percentage of triple-negative patients is there any estimation of how many people fall in that category? And then a related question on that is, someone's tumor was tested to be not positive for PDN1, but would that potentially change over time?
So the answer to would it potentially change over time is yes. Mm-hmm. Tumors can change, and it also looks like the site of biopsy could potentially influence the likelihood of detecting PD-L1 positivity. Okay, so again, what I want to say as a general caveat is that our information keeps on changing. Okay, so please don't take first of all, don't take what I say as gospel anyhow, but don't take what I'm saying now as being what we might say in 3 months or 6 months or a year, because our information keeps on changing. But there's some data that suggests that liver biopsies are more likely to be PD-L1 negative than lymph node biopsies. And again, that's based on today's information, so we don't know whether that's really true, but there's some suggestion about that. So that could influence things, but it's also possible that over time the PD-L1 status changes. And again, we don't have a ton of information on how frequently these tumors are PD-L1 positive. From one of the trials, the suggestion is somewhere around 30 to 40% might be PD-L1 positive. But I think we need to gain more information. We have another trial that is coming out soon. And then the final thing that I just want to say about this that's really important is that as a medical community, we spend a lot of time, there are lots of different tests out there to determine whether something is PD-L1 positive or PI3 kinase mutation. What do you mean by a PI3 kinase mutation? So the technical aspects of it matter. It can change from tumor subtype. There are different assays that have been developed, and that's something that we are going to need to figure out how to standardize so that we understand. And when HER2 first came out, I can't tell you how many studies were out there to try and figure out what do we mean when we say a tumor is HER2 positive? What assay is being done to determine that? What level, what's positive? Is positive above X% or Y%? So these are not, while they sound rather hard and fast, it's actually, there's a lot behind that, and I don't think we yet have the standard way to measure PD-L1. And I'll tell you that different companies have developed different assays as companion assays, and so it'll vary, and different tumors have different ways of measuring it. So in breast cancer right now, when we're talking about PD-L1 positive, we're not talking on the tumor, we're actually talking on the cells that are surrounding the tumor, the white blood cell components that are surrounding the tumor, so it's not actually the tumor cells. But for other cancers, they're looking at the tumor cells. So again, this is a very nuanced and complicated space.
Erin?
So we've had a lot of great conversations about clinical trials. One person has commented that their doctor has not been very enthusiastic about their questions about clinical trials and said to take them with a grain of salt. But this person is really looking for resources on clinical trials. You've mentioned a number. So what are some resources? How can we direct? Where's a good place to go to find out what clinical trials are available for you to navigate that? What resources could we recommend for that?
I'll answer that.
Yes, please.
Yeah, I'm
I
so
think
glad.
we all want to answer.
I know, we're like, oh, we'll go down the line. This is really important because we know the studies have been done to show that of the patients that would actually benefit from clinical trials, less than 20% are actually enrolled, and far fewer represented from our communities of color. The number one reason why this is happening is simply because patients are not being asked, and it pains me to hear that someone feels that you should take it with a grain of salt after Dr. Isaacs has talked so passionately about the importance of investing in discovery and participation. So So if you are interested in clinical trials, we're going to go down the row here. Komen has actually a clinical trials helpline where you can call one of our trained oncology social workers, and they will talk to you about your eligibility for a trial and give you questions to ask your doctor, and that's available toll-free at 1-866-GO-KOMEN. Well, not 24 hours a day, but quite a long time during the day. I'll pitch to you, and then I'll...
No problem. I wanted to mention Metastatic Trial Search, which is available both on Komen.org and lbbc.org. It's a trial search engine only for people with metastatic breast cancer, where you can put in the subtype, and you can even put in the site of metastasis, and it'll match you to trials within your region. And I also wanted to mention MBC Connect, which is a new product by the Metastatic Breast Cancer Alliance that's going to connect with the trial matching service. So it gives you a number of surveys that you can answer about your experience and about your subtype. And the next version of this, which is going to come out in a couple of months, will actually match you to trials that are in the metastatic trial search. So those are two good resources that you can try.
And then there's the government site, clinicaltrials.gov, which can be a little bit of a challenge for all of us to navigate. But it is, it does pick up a lot of the trials, and it's just a matter of understanding some of the lingo, which you really have to, make sure that you're looking at trials that are actively recruiting subjects, because it will have trials that are closed as part of it. It has a geographic basis, it has the subtypes. But it can be a bit cumbersome, and I know that they're trying to update it and to make it a little bit more user-friendly.
I also want to mention Emerging Med, and then something kind of unofficial, which is social media. If you go on social media and ask your fellow patients with metastatic breast cancer about particular trials that you're looking for, you will find a gold mine of information of other people who are also looking for that information. So I would encourage you to ask your peers.
Another thing I want to mention about getting connected to clinical trials, we talk about informing the patient about where to find this, but we also have to address the other toxicities and lifestyle issues that prevent people from going on and staying on trial. It costs money to go to the trial site every single week. Somebody has to watch your kids while you're there. You need to take time off of work to get your treatment. And there's a lot of complexities as to why people don't stay on. Maybe you're having side effects, but your insurance doesn't cover that medication. So it's important that when we're talking about resources, that we also address those issues. Both of our organizations have helplines that connect you to sources of financial support, to support groups, and to other ways that you can access to keep you on your treatment. We have to think about the whole patient experience and what's happening with you, your personal experience, your family, and your work as well.
And most institutions also, we have social workers, we have people who are trying to help with all of this. Obviously, we often refer out to organizations, but there are organizations that can help, because we all recognize that often clinical trials do require more of people. They require more frequent visits, they require longer visits, they require a bunch of screening and pre-screening and a variety of things. But I would urge you that if your clinician is telling you they're not interested in clinical trials, and take it with a grain of salt, go and ask around. And you might decide, clinical trials, there might not be good clinical trials there. The clinical trials that are there might be good for somebody, but not for you, and you might not want to do that, and that's fine.
That's okay.
But you need to know what all your options are. And, particularly in this era where we really, we just have new things coming out all the time. It's really important to know about it, and you could potentially make yourself not eligible for a clinical trial that you might have wanted to participate in by starting on a new treatment. So, and thinking back to one of the questions that you asked me earlier, how do you choose which treatment? Honestly, I think I sometimes find myself playing chess and thinking, okay, if I start this now, what clinical trial might I make this patient not eligible for tomorrow if I do this drug? So if I have a choice of 3 drugs, and if I choose one drug, I know that I might make somebody ineligible for a trial for the next line of treatment. And I have 3 equal options. I might not choose that. I tend to have that conversation out loud with the patient who's in the room so they understand what I'm thinking. And I always say, I don't know whether that trial will be open at the time that we need it, but I'd hate to make you not eligible for it because of a decision that I'm making today. So it's gotten increasingly, I think, complicated to think about what, because you have to know what the next generation of things that you might be able to offer somebody, what its companion might be, and what the 25 eligibility and ineligibility criteria might be. So I always urge people that when it's at a time of decision about next therapy, usually there is not an urgency. Like, you don't have to switch chemotherapies today. You really, again, there are no alwayses and no nevers in medicine, okay? So usually, the vast majority of people have time to sit back and think about this for a little bit. And that gives you time to explore what are other options. And I always tell people that, the reason with clinical trials these days, there's a lot of things that are standard of care that we can write that are FDA approved and that people can give to you, that your clinician can give to you. But the clinical trial might only be an option in this point in time. So, say, okay, don't change my chemotherapy today, or are there clinical trial options? What's going on in this place? And it might be that there isn't anything, okay? But don't feel like you have to be rushed into a decision at that moment, because that might close some doors for things that you might have been interested in.
Thank you so much for saying that. It is becoming more complex on our physicians as well as the patients. We do talk a lot about patient education and patient advocacy, but we also need to support our physicians in understanding the huge explosion of information that's coming out. It really is a partnership, which is nice for us to be having today. So any further questions from Erin?
To link on the theme of partnership, we did get a question about the role of patient advocates in some of those FDA decisions. That is there any way that advocates and the broader metastatic breast cancer community can help encourage faster FDA turnaround, those sorts of things? So any tips, maybe from the whole panel, but any strategies around increasing the urgency for getting these drugs available to everyone?
Go ahead, Janine.
I'll do my best to answer that one. So there are a lot of opportunities for patient advocates to be able to participate in the process. And as an advocacy organization, Living Beyond Breast Cancer, and also Susan G. Komen can let you know about opportunities where you may be able to write letters or actually testify before the FDA to make your voice heard. So that is one piece of how you can contribute. Another is to be active both with your personal physician and healthcare team and institution, and on social media where it is appropriate, to apply some polite pressure to have changes made and to make your voice heard. And I would say a third strategy is to talk to organizations like ours and give us your input. Tell us what it is you want and that you need. As Victoria said this morning, both of our organizations are members of the Metastatic Breast Cancer Alliance, and this is a priority for our alliance, is to address some of the barriers to clinical trial participation and to make sure that your voices are heard about what you want and what you need and what the outcomes should be. So there's a lot of people who are really interested in working with you and advocating with you to have changes made.
So I'll talk a little bit about advocacy. You said polite pressure, but sometimes...
Sometimes impolite pressure.
Sometimes impolite, yes. Bring your pitchforks and torches to the Capitol, everyone. But we do need to have our
You're on
voices...
film for that.
Yes, my advocacy team knows I've said this, but it's true, right? Sometimes we're a victim of our own success in this advocacy space, that there has been progress, but we all know in this room the work is not done. We need to continue to put pressure on our elected officials and continue to participate in raising the voice and participating in research for progress to happen. So I can't underestimate the importance of the advocacy space. Komen has an advocacy event. Our colleagues at Metaviver have the Metastatic Stampede, which is happening in October, which is an incredible opportunity to bring light specifically on the need to raise the profile of metastatic research of all types. The letter writing is also important. But I want to go back to participating in the research enterprise. One of the challenges we have in getting drugs to the market is the lack of people participating in trials. Sometimes that's because people aren't asked to participate, and sometimes it's because the trial has been designed not to have the patient in mind. It's really important that our research advocates like Jamel work with our researchers and with our industry colleagues on how to design a trial that's most conducive to patient participation. You all can weigh in that, hey, me coming to a trial site 5 days a week is not going to happen. Let's design this so it's more friendly to the patient so we can ensure accrual, we can ensure that we get the answers that we need, and that we also can ensure that we're representing a diverse population. This is one of the challenges that we have in the drug development enterprise, that a lot of the work and the studies are being done with people who look just like me, and that doesn't represent the face of breast cancer. It's really important for us when we're talking about drug development and approvals that we're assured that what's out in the marketplace works for every member of the community. And if that doesn't work, what can we identify that does? I know it's a little bit different off the topic of FDA approval, but I'm very passionate about this because we need to represent everyone who is facing breast cancer, whether it's women or men or any other member of the community. The drugs need to work for everybody, so advocacy is very important.
And I will tell you, participating in a number of groups that do breast cancer research and do design clinical trials, the good news is that I think a lot of us have gotten this.
Yep.
We have, as active members at the table, breast cancer advocates. So, we're at Georgetown, we have a group just for our own institutional trials. We participate in what's known as the Translational Breast Cancer Research Consortium that has a big advocacy group that is part of it and that is on each conference call for the subtype of breast cancer, and we're discussing it as part of I-SPY 2 and a variety of other trials. The cooperative groups have advocates on it, so I think everyone increasingly gets it, which is good because all of us can be a little tone deaf sometimes. And there are also clinical trials at institutions often that are trying to see if there hasn't been good representation, broader representation, to try and look at the safety of that drug in other groups. So for instance, my colleague Felipa Lintz, who's in some other room close by speaking Spanish, which I can't do, just ran a trial looking at the CDK4/6 inhibitors in women, in Black women, because they typically have lower white count to start with. It's called benign ethnic neutropenia. So it actually doesn't mean anything, and it's not clinically impactful, but because these drugs can cause the white blood cell count to go down, there was a set cut point for a white count to be able to participate in that trial, and it excluded people because of that. So, she just completed a trial looking at the safety of CDK4/6 inhibitors in people who have benign ethnic neutropenia to show that they were safe in that space, and that's often what we need to do. And so there are lots of different places where people can think of that. And I guess that just the one other plea, and I guess clearly I wear a clinical trials hat, but participating in clinical trials is critically important. Because when we're talking about doing something better means a lot of things, okay? Better, obviously, first and foremost, means better outcome. But if we could get the same outcome with less toxicity, that would be even better. So there are trials, we are always trying to do better, okay? That's what we want to do. We want a different future tomorrow than we have today, and that's really where clinical trials get us.
Thank you so much for the shout out for the importance of clinical trials. It's imperative, especially for this group, that we need future discovery. We need discovery now, we need it sooner. So thank you so much. I just want to give a shout out again for the phone number for the questions via text. It's 610-365-7532, and Erin is standing by waiting for your questions. But I think we're ready to move on, Janine.
Yes, absolutely. So speaking of clinical trials, let's move into talking a little bit about HER2-positive breast cancer, where clinical trials have really revolutionized the treatment of this subtype of disease, as you were reflecting when we first started talking. So you spoke a lot in the ER-positive setting and in the triple-negative setting about how we sort of pick and choose the order of treatments. In HER2-positive metastatic disease, we actually have some guidelines about the order of treatments. Why is it so much different in HER2-positive breast cancer?
Again, it probably has to do with the place we are right now, okay? And the trials that really revolutionized the treatment of HER2-positive breast cancer, they're now 5 years old, or 6 years old, or 7 years old, whatever, wherever we are and all of that. So there has been time to get data on doing what next. So we have clear guidelines on first-line and second-line therapy because we've gotten there. But we don't have guidelines on third-line and fourth-line and fifth-line therapy, and that's where there's a lot of active work in clinical trials to try and define that. So, maybe to get back to the concept of clinical trials, I always say that today's clinical trial opens up tomorrow's question. It answers one thing, but we then need to figure out what we do next based on that. So the reason that we don't have guidelines on what to do in hormone receptor positive, HER2 negative after CDK4/6 inhibitors is they're too new, okay? And we haven't had time to gather the data. And the good news is that often when you introduce these drugs, they change outcome for people. So you have a period of time where people have long stability, and we're not even able to scientifically and medically address the question about what the next best therapy is. So for HER2-positive breast cancer in the late 1990s, when I was first starting, trastuzumab or Herceptin came along and totally revolutionized the treatment of HER2-positive breast cancer. Trastuzumab or Herceptin is an antibody that is geared towards HER2-positive disease, or to the HER2-positive aspect of the disease. Subsequently to that, there was a trial that came out in, I can't remember when, 2012-ish or something like that, 2013, that looked at adding another antibody on top of, I'll call it Herceptin because that's what most people know it as. And the other antibody, I think most people know it as Perjeta. Its other name is pertuzumab. And so there was a large international trial that randomized women who were receiving first-line therapy for metastatic HER2-positive disease to either the chemotherapy plus Herceptin, which was then the standard of care, versus chemotherapy, Herceptin, and Perjeta. So asking the question very clearly, what does Perjeta add over and above? And it added a ton. It prolonged survival by about 15 or 16 months, which was really huge. And those women had, in general, disease stability for, on average, about 5 years, which is, not great, but a whole lot better than what we were doing before. But after that, we had no idea what to do after people progressed. And then trials came out with another drug, a drug called TDM1 or Kadcyla, that showed that it was very effective in that space, and that's become the second-line therapy for people who have disease progression. So now we have a very clear algorithm for first thing and second thing, but we don't know what to do third and fourth. And for a long time, the good news was that we couldn't really even study it because people were doing so well that we weren't able to actually get studies designed and accrued to address those questions. But there's a lot of activity in that space right now. So there are a lot of new drugs that are making their way fairly far along in clinical trials that are looking at different ways of targeting HER2. There's another drug out there. There's a drug called lapatinib or Tykerb, which is FDA approved. So there are other drugs that we can use, but there are also novel antibodies, drugs that hit the HER2 pathway in a different way that are being looked at. So there's a lot of activity. And what, again, if I'm saying this over and over again, but if somebody has HER2-positive disease and has received Perjeta already and TDM1, I would strongly urge you to think about participating in a clinical trial at one of these other drugs. Because yes, what we do then when somebody has disease progression on that is to use Herceptin again with a different chemotherapy. But again, we think that some of these new drugs might be better, and we won't get those answers unless we can study them and really look at some of these newer drugs. But there are now, there are a number of drugs, and immunotherapy is also being looked at in this space because HER2-positive breast cancers might be more immunogenic, by that I mean might be likelier to respond to immunotherapy. So there's a lot of research activity going on there to try and define the next best things, but we have really great and effective therapies in first line and second line.
Are there any particular agents that you anticipate in the next couple of years maybe on the road to approval?
Mm-hmm. There are a few. Some of them have, just letters for their names, so they're not very recognizable. There's There's an oral drug called tucatinib that people are really excited about, the concept of immunotherapy. There are other drugs that have, DS, I can't remember its numbers after that. So there are other drugs out there that are really exciting, that have made their way into more definitive phase 3 clinical trials that have shown a lot of promise. So I think there's a lot of activity there. And I guess the one other thing that I thought of as you were asking me this question, maybe taking us back, and I know I'm melding the subtypes a little bit, but there's some general principles. I tend to, right now, I don't put everyone on clinical trials. If we have great standard of care, there's no way I would want to risk that for something shiny and bright that looks like it might be better but might not be, okay? So I think right now, in hormone receptor positive, HER2 negative, first line, I do a CDK4/6 inhibitor and endocrine therapy. There may be trials that are asking about adding something over and above that, and that might be worth it. But I would think of that as, the standard thing that one would want to do to start with, because it really has, we do have great standard therapies, and we have a number of great standard therapies. In HER2 positive, I would do the Perjeta, Herceptin, and chemotherapy for the, as the first standard. And maybe there are trials that are going to be looking at adding immunotherapies, and that might be worth it too. But I, again, would not think about changing something that is really tremendously effective for something new and fancy that we think might be, because sometimes those things don't pan out. It doesn't mean that one should ignore clinical trials in that space. That's not what I'm saying. But make sure that your healthcare team explains to you what that clinical trial is and how it compares to today's standard of care. Because you really need to be making an informed decision, and you have every right to ask those questions and should ask those questions about what is the standard of care. And the consent form should say what the standard of care is. And those are rules and regs, and all clinical trials go through a lot of regulatory processes to make sure that in the consent form, and your healthcare team should tell you what would be the standard of care and what would I be trading off by participating in a clinical trial.
Absolutely. Absolutely. So thanks for addressing that. And you had mentioned about HER2 negative, estrogen receptor positive cancer. What about for people who have both hormone receptor positive and HER2 positive disease? There seems to be some suggestion there that type of cancer may respond differently. What is the standard of care now, and what is the research into looking at so-called triple positive breast cancer?
It's a great question, so many great questions. So triple positive has all of the targets, right? So which target do we choose to hit? Because we have lots of good options. And we feel that HER2 is a really important target to hit, because it is a very potent driver, and we want to shut that pathway down. Okay, so the standard of care answer, where are we? February still, right? February 2019 would be to do chemotherapy for a certain period of time. We're talking about first line here, so chemotherapy for a certain period of time with the Herceptin and the Perjeta. And then after about 6 to 8 cycles of chemotherapy, you drop the chemotherapy, and at that point would start the hormone therapy, okay? And that would be the standard answer. Right now, you could say to me, well, why do I have to give chemotherapy with it? Because who wants chemotherapy? And could I just do hormone therapy with it? And we don't have good trials now to show us that that's as effective, but there's a lot of research that's going on there to see whether we could get rid of the chemotherapy aspect of it, because hormone therapy is better tolerated. But if you have a clinical trial that shows you with chemotherapy a 15-month or 16-month prolongation in survival, it's a little hard to risk losing that benefit, right? But we're trying to figure out if we can do that, okay? So the standard would be to do the chemotherapy with the Herceptin and Perjeta. After the chemotherapy is done, after about 6 months or so, or 6 to 8 cycles, you drop the chemo part and you add the hormone therapy. There's also a question, okay, I've told you in hormone receptor positive breast cancer, we should be using CDK4/6 inhibitors. Should we be doing that too in HER2 positive or not? So there are trials. There's actually a big trial, a national trial that is looking at that question. It's having a really hard time accruing, but it's a really, really important question. So it's randomizing women who have triple positive breast cancer after they finish their first 6 cycles of chemotherapy and are dropping it. Should you be just doing the endocrine therapy and the Herceptin Perjeta, or could you add the CDK4/6 inhibitor on top of it? Because that's not standard right now, and we don't know how to integrate CDK4/6 inhibitors in HER2-positive disease. So we really need to look at that. But that's how we generally approach it, is to start that way. And to try and figure out how you treat both can be complicated. And really, it's one of those things that I think is very individualized. But the good news is there's tons of targets, okay? And there are tons of active drugs there. So that's a really, that gives somebody a lot of options of treatment.
Dr. Isaacs, what is the name of that trial? Do you
It is called, give me a second, it is called the Patina trial.
Patina trial.
But somebody should check that for me who has a smartphone on them.
We can absolutely do that. Don't mean to put you on the
have different
spot.
names, but it's Patina, Patina.
Thank you. Sure. Thanks for that. So one of the challenges of HER2-positive metastatic breast cancer, and also sometimes in the other subtypes as well, is brain metastasis. And I wondered if you could talk a little bit about the treatments that people might face after a progression in the brain.
So again, a really good question, and a clinical space where we really need to think hard about the best thing to do. So typically, when we're treating metastatic breast cancer, we need to think about treating the whole body, right? But there also may be times where there's a specific site of disease that is causing a particular problem that we need to address. And then we need to think about addressing that specifically. And one of those instances is with brain metastasis. And I mean, if we think about it, right, we have, innately in all of us, we have what's called the blood-brain barrier. And it's there because, as you can imagine, our body is designed to keep bad stuff out of our brain, right? We don't want everything going there. We want to protect it. So it's considered what we think of, or what we often call as a sanctuary place. So chemotherapy would count as bad stuff, right? And so chemotherapy doesn't get into the brain. We don't know that drugs like Herceptin and Perjeta, which are relatively big molecules, whether they cross the blood-brain barrier. So it's a sanctuary site where our standard treatments may not get. And again, not all of this is truth, okay? That's what we think, but it's possible that with brain metastasis, that blood-brain barrier is disrupted. So maybe our standard rules or our standard understanding doesn't apply to things. But we can often see in women with HER2-positive, we can see in women with HER2-positive breast cancer that the disease elsewhere, the brakes are on it, it's shrunk, and things are good, but a brain met pops up, or some brain mets pop up, and so we need to deal with that. And the way that we typically deal with that today is more in a focused local therapy approach. So that's where surgery and radiation might come in. And again, it depends on how many brain mets, how big are they, where are they, what sort of problems are they causing. But usually we can't ignore them. They might be teeny tiny, in which case we can watch them. But if they're more than teeny tiny, usually we feel like we need to address them to prevent symptoms from developing or progressing if there are already symptoms present at that time. So typically I turn to my neurosurgical colleagues and my radiation oncology colleagues. Radiation has gotten better, okay? So we now have growing data. We used to only offer what's called whole brain radiation, which had a fair amount of toxicity with it, and particularly on the long term, could have effects in terms of cognitive function. But increasingly, we have data that our radiation oncology colleagues can do what's called stereotactic radiosurgery. So there are lots of different methods. You know, our institution uses CyberKnife. That's one of the more common methods, but there are other methods to do it. So they're really pinpointing the tumors more specifically. So they're not hitting all the normal tissue, but they're hitting the tumors themselves. And we used to only do I'm not a radiation oncologist either. we, the medical community, used to only do CyberKnife if there were, just 1 or 2, and now there's data that you can do it up to 10 maybe, depending on how big they are and what's going on. So sometimes that's what's done. There's also for women who need whole brain irradiation, there's increasing work that shows that you could be able to spare the memory part of the brain, what we call the hippocampus. And so there are some techniques where they spare that with whole brain irradiation. So the decision about what to do is really based on a number of factors. There are also some of these drugs that target HER2. One of the reasons why we have a lot of interest in drugs like tucatinib is that it's a small molecule, and we think it crosses the blood-brain barrier. So we have some suggestion that some of our whole body treatment might actually also be able to get into the brain because it's small enough that it can bypass that mechanism that keeps it out. So there's a lot that's going on, but typically we need to pause. We need to treat the brain mets, and then we need to assess, does that impact our whole body treatment or not, or can we continue it? So, I have a number of patients where we paused, we treated the brain met, we kept them on their same whole body treatment, and, they kept on going and things kept on going. They've done very well for a long period of time. So the other thing that I would urge people to know is, sure, brain mets is scary, but what's out there in the literature suggests that it's associated with a really short lifespan, and that's not true. Things are much more complex than that, and people can be living for years and years and living well, having had treated brain mets. And so I really want to make sure that everyone understands that and knows that. And one of the reasons that in the breast cancer world and in oncology in general, we're trying to, again, do trials that minimize toxicity with radiation. So, we want people to be living well and functioning well for those years to come. So that's why it's so important not to impact cognitive function, not to impact somebody's day-to-day living with the treatments that we're doing. And I know, you all know, you more than anyone know how the side effects of what we do, but I want you to know that we as providers are thinking about them too, and we're really trying our best to pick the one that minimizes the side effects because, we understand, and what we're trying to do is, again, having people thrive and live as well as they possibly can.
Thanks for that, Dr. Isaac. That's wonderful. I think we probably have some folks in our audience who are thinking they want you as their doc, would be my guess. So with that, I'm going to go to Erin and see if we have some questions because we're getting close to the end of our time together.
Following up on the brain mets conversation, one person is asking, what is the symptoms of a brain metastasis? They comment that their experience is that insurances are often denying MRIs, but so symptoms, and then what would be the process to detect if you do have mets to the brain?
So symptoms of brain mets could be varied because it depends very much on location. Our brain is really mapped out that they have specific sites that control language or movement of your right hand and all of these things. So it could be anything that typically it could be more something like weakness or funny sensations in a more what we call focal way, usually one side and not bilateral. Both sides, the brain is actually the opposite, it controls the opposite side, okay? So typically if somebody has a brain metastasis and there's impact on function or weakness or sensation, it's one-sided because it's in a particular location. It could impact speech, there could be headaches, there could be nausea and vomiting, there could be a variety of things. The question about how we detect them, MRI is clearly the most precise to identify even very small areas, but if somebody is symptomatic, a CT scan with IV contrast typically would pick something up. These are pretty good scans as well. So they would pick up something that was big enough to cause symptoms most typically, but most of us would go to MRI as our first choice, but CT scan with IV contrast is also a good study to look at.
Thank you. Erin, we'll take our next question.
Yes, so a question about the role of liquid biopsies in monitoring for progression. What's your thoughts on that?
So liquid biopsies can mean a lot of things. It's a great term. Okay, liquid biopsy means something on a blood test, right, is what it means. And there are lots and lots of different techniques that have been developed to look at markers of either response or detecting a specific mutation or other things. Probably probably an old school liquid biopsy, which is not a liquid biopsy, is to think about tumor marker tests that have been around forever. Now those are markers that can be elevated in the blood that can track with disease status. They can be extremely reliable in some people, but hugely unreliable in others. So again, that's a very individual thing. The fancier types of liquid biopsies are looking more at either circulating tumor DNA, so DNA from the tumor that's shed into the bloodstream that can be measured, or looking at circulating tumor cells that we abbreviate as CTCs. And the CTC number or cut point and response in terms of therapy has been shown to predict outcome in people. But these are not standard of care right now. These are really more being integrated. CTCs for a brief while were being covered by insurance, but not anymore because it's not clear what their role is compared to other tests. So it's very hard to do them routinely in practice because they're very expensive and not covered. But increasingly, techniques are being studied to try and have markers that we could measure on blood as opposed to subjecting somebody to a biopsy. But right now, they typically are not standard of care. They're typically within the setting of clinical trials.
Thank you for that. Erin, we'll take another question, please.
We did receive a question about natural healing as an alternative to traditional medical treatment for metastatic breast cancer. Is there ever a case where that would give you give you positive outcomes in terms of controlling metastasis? So forgoing any sort of treatment for natural healing. Sort of what is the recommendation? And there was a comment about the fear.
You are asking a traditional doctor that question.
Right, yes. That I think they
but
were aware of that.
I'm going to bring some evidence to this traditional doctor.
Right.
There's actually.
And just a
yes.
quick comment. I think there was a comment about the fears of all of the side effects of chemotherapy and sort of balancing that. And there is a lot of, thoughts about including natural healing as an alternative, but also as a complementary therapy. Maybe talking about how to use both practices to manage side effects and the evidence we know about not doing any treatment.
Absolutely. So let me talk first about the alternative instead of.
Yeah.
Okay, which is very different than is in complement with or complementary. So we have very effective treatments that we know prolong life. And I know I've been sort of, somehow we haven't talked about the standard chemotherapy, but it is part of the treatment, okay? And it is an important part. And we are 2019, and we have great drugs to help manage the toxicities of chemotherapy. Not all of them, and none of us should suggest that it is nothing. It is not nothing. But there are a lot of people out there, and many of you might have been in those shoes at some point, who have gotten chemotherapy, and people would pass you on the street and would not know that you were getting chemotherapy. So there are a lot of very active chemotherapy drugs out there that can be well tolerated or can be well managed, or whose toxicities only start to appear after a certain period of time, at which point in time the decision is made that this is not tolerable and we need to do something else, but one can get some mileage out of it. So I don't want to leave here with this concept that we should not, I would be lying and not be truthful to you in terms of things. Chemotherapy is part of our treatment. At some point, for most subtypes of breast cancer, we're going to be talking about it, but there are a number out there that are manageable, okay? Alternative therapies instead of standard therapies, we've all seen people who have come to us after that, but there's a study that just came out that looked across cancer types and showed a much higher mortality rate and quicker mortality, lower survival in people who chose alternative versus standard treatment. So we actually have data now to back it up, and that was sometime in the last year that this article came out that looked at across a large swath, looked at that as an outcome. Complementary, I think, is different, okay? And I think it depends on what we're talking about in terms of complementary. You know, we have to exercise some caution with some of the complementary therapies, right? You know, our chemotherapies are derived from, some of our chemotherapies come from plants, okay? So plants are not nothing. Plants are compounds and chemicals. They're packaged and they're more appealing, okay? But they're not nothing, and they can impact things, and they can have side effects too. But they can impact the way that one's body metabolizes any other treatment that you're getting. So it's possible that by doing a lot of complementary stuff at the same time as standard therapy, they're either reducing the potential for efficacy of the treatment and or increasing the risk of toxicity, because the enzymes that break down these drugs, you know, they often use similar enzymes to break down lots of drugs or lots of compounds. We call them compounds. Compounds are drugs and complementary and all sorts of things. So there is a risk of minimizing some of the efficacy and a risk of increasing toxicity by some of these drugs. So I tend to tell people, you know, just be careful, okay? You know, multivitamins are fine. The other thing about complementary is that it's not well regulated. So what you get one place might be chemically very different than you get somewhere else, and so that can be a problem. But we have evidence for efficacy for some of complementary stuff. Like we have really sound clinical trials now showing us that acupuncture manages symptoms, okay? And they're really well done clinical trials that have shown that hot flashes are reduced by acupuncture. Joint achiness from AIs is reduced by acupuncture. And that's well done clinical trials that did compared randomized women to acupuncture at the right spots, which I have no idea where they are, versus sham acupuncture. So basically somebody was, you know, putting the needles in the wrong spots for those symptoms. And the right one made a big difference and the wrong one made less of a difference, okay? So it's real. And I think things like that, you know, your healthcare team should be talking to you about that to help manage some of the side effects. But I do exercise some caution with, you know, complementary medicine. I would not do it instead of standard, because the standard stuff prolongs life, okay? And I would exercise some caution to make sure you tell your team if you're doing complementary stuff, what complementary stuff. There are a couple of really great websites that look at the potential for interaction and the safety of some of these complementary products to look up and to see, and that many of us use. I mean, so Sloan Kettering has a great complementary medicine website, which we use all the time when people talk to us about that, or we suggest that they look and see how that interacts, because sometimes people come with shopping bags, right, of complementary things, and you know, there's not enough time for us to go through all of that, but before you start that shopping bag full of stuff, go to that website and see how it might interact with what you might be on, but make sure you tell your healthcare team as well.
Absolutely, and I was just going to add, for those who are interested in integrative care, there are some places that you can go, some healthcare facilities that actually have integrative care programs, so you'll meet with physicians who may have more experience using some of these modalities or using nutrition as part of the treatment. But as Dr. Isaacs said, what's really important is that if you're interested in these types of therapies, to discuss it with your healthcare provider, because just because they're natural doesn't mean they don't have an impact.
Can I just make a comment about some of those? So I personally feel more comfortable with integrative sites that are part of the standard healthcare community, not these standalone sites. Some of them are great, okay? But make sure that they're not telling you don't do this and don't do that. That is standard, because we're not, you know, we're not doing what we're doing in the traditional medical community to, you know, our main thought is to improve your outcome, okay? I could bring you stories of things that I don't understand. I don't know why this standard treatment or this experimental treatment worked in one patient but not another. But that's not fair. We shouldn't be practicing anecdotal medicine. It's not evidence-based. So some of these places promise things and say these things, but we could all bring out examples and say it's because I'm such a great doctor that Mrs. Jones is doing well. That's not true, okay? There are factors that are beyond what I understand, and I should not be using that as a promotion. So please be careful. Please think of these things. Please talk with your standard healthcare providers about things, because anecdotes is not evidence-based. Anecdotes are, this is complicated stuff and we don't understand it, and we shouldn't be trying to sell something. And hopefully I hope that you trust your healthcare team, that they're not trying to sell you something, because that's, hopefully we went into this because we want to be making a difference, and we want to be prolonging people's lives and helping them thrive well with it.
Thank you. Erin, I'm going to go to you for one last text question.
Yeah. So this is a question commenting with those living with metastatic breast cancer are living longer and may have many scans over their life. So is there any impact to exposing your body to those ongoing scans? Any comments on that?
Another great question that we don't have a good answer to. So we think about that, and we often prolong the interval between scans if people are doing well, okay? But we also don't want to let it go too long, which is also why we're trying to develop liquid biopsies. So I think it's part of, that's a great question. It's a question that we're asking ourselves, that we're trying to figure out how we can minimize. I think for the time being, it's what we have as the standard, and it's really, we have to monitor things because we don't want to also be exposing people to ongoing side effects of therapies that are not effective. And that's the way that we figure out whether our treatments are being effective. But we're working hard to develop different means to help complement that. And then on an individual basis, if we have somebody who's been coasting for ages and doing really well on a treatment, then we do, expand the period of time between scans often.
Thank you for that. And Victoria and I would like to thank you, Dr. Isaacs. Is there anything you'd like to add before we wrap up our program?
No, just thank you to all of you, and for your organizations who make such a difference, and to all of you who are here.
Thank you, Victoria.
Okay, and thank you, Janine, for moderating an incredible session. So we're going to say goodbye to our friends on Facebook for now, right?
We are going to say goodbye and just let you know that, that this recording will be available on the live stream immediately following the program, and it will be on both of our websites within a week. So please come back. So let's say goodbye to our live stream audience and give them a hand for joining us today. Thank you.